Thank you, Teani. Good afternoon, everyone. Today I'll be speaking on winners and losers, amyloid versus tau versus glucose versus others, and developing better Alzheimer's treatment with better detection and monitoring with EEG. And I just want to make sure everybody can hear me okay. And if you can, just give me a thumbs up there. All right. Thank you so much. And actually, I can't see myself in the video as well. For some reason, having a little technical difficulties this morning. So thank you for your patience. And I hope I'm doing okay. If I'm not, feel free to interrupt me. I do have some disclosure. This is my disclosure from the research funding received from all these organizations. Yeah, and if anybody else wants to fund me, tell them to come and talk to me. I'm totally open. I look forward to working with all these wonderful people. So we have a couple objectives to cover today. First, we want to cover some mechanistic pathway of Alzheimer's. Second, we want to talk about what are some of the challenges with the Alzheimer's research, and why aren't we making progress as quickly as other diseases, such as heart disease or cancer, and basically, what's really holding it back? Could it be the biomarkers? And the third thing we want to talk about is what are the current biomarkers and what are some of the barriers. The fourth thing that I want to talk about is potentially pitching neurophysiologic cognitive signals as a potential non-invasive, widely available and cost-effective biomarker. And last but not least, I want to tell you about what we're doing here at the Memory Center and share a little bit about what some of the research that we're doing here at the Memory Center. So everybody knows about the amyloid cascade hypothesis, which has, if you've been in this field as long as me, you knew that this has been the predominant theory that drove some of the therapeutic developments. Everybody knows some of the common products, such as the one that was recently approved last year, aducanumab. There are several ways to drive down the amyloid by either decrease the production, by many of us have been involved in the beta gamma secretase inhibitors, which cleave the amyloid precursor protein, which is a protein inside the membrane, or you can decrease the amyloid by inhibits the aggregation, like many of the biologics are now doing, including aducanumab, or increase the clearance. So there are many ways to tackle this amyloid cascade. So amyloid being a predominant theory that has been driving the therapeutic development for the last 20 years, at least 20 years. It seems like if you've been around for that same amount of time, it seems like everything seems to revolve around amyloid, and whether you have a tau theory, oxidative stress, neuroinflammation, synaptic loss, so it seems like the whole world is revolving around amyloid. I really like this schematic proposed by Richard Ralli from Italy in 2017. It doesn't really matter what I feel. So what does the NIH really feel about the amyloid theory? So funny that you might ask this question, because I was looking on the NIH website, and just July 29, NIH put out a statement on amyloid beta protein dementia research. It mentioned that Alzheimer's has been recognized as complex, that involves many other cellular changes in addition to the accumulation of beta amyloid. The NIH support a wide range of studies. So let's take a look of the NIH studies that were supported of the late phase. We're talking about phase 3. 5 out of 8 are focused on amyloid. But on the early phase, we're talking about phase 1. Guess what? Less and less are being focused on amyloid, only 13 out of 62. So even NIH data and their sentiments are moving towards there is a progressive diversity. Perhaps we need to take the approach, instead of focusing so much effort and time on amyloid, perhaps we need to diversify our approaches to pursue solving this problem. So just to give you a perspective of the drugs that are in development in pipeline, this is an article from Alzheimer's Association for Drug Development Pipeline 2022. So with the top graph, you see the phase 3 study. Obviously, majority are in the DMT, or disease-modifying therapies, the green pie. And you can see that out of those 68%, 21 of them, 31 agents in phase 3, 21 are in disease-modifying. You can see that still about majority, 6 are in amyloid, and let me see, 5, 1 in tau, and also a significant number 4 in synaptic plasticity neuroprotection, 3 in oxidative stress. But if you look at phase 2, more early phase development, there are more agents, 82 agents, obviously, because as you go to phase 3, some will phase out. So out of phase 2, 82 agents, 71 are in disease-modifying therapy. And out of those, only 16%, as opposed to 29%, are amyloid. You can see that inflammation immunity is really catching some popularity. So is synaptic plasticity neuroprotection. So it seems like even in the drug development pipeline, at least in the early phases, things are sort of moving away from amyloid, and there seems to be a diverse approach, including metabolism, vasculature, immunity, synaptic plasticity. So my goal today is to at least touch on a few and to give us an idea of where we think things might be moving in this area. So here's another look at where we are in the drug development pipeline. This is an article published again in 2022. So looking at amyloid, still at the bottom, still predominant at about, and the green is phase 1, the yellow is phase 3. So about 6 in phase 3, 11 in phase 2, blue is in phase 2. And also very popular is inflammation immunity. Tau as well. Those are the 3 big ones. But what's really catching up in phase 2 and phase 1 is the synaptic plasticity neuroprotection, vasculature, oxidative stress, metabolism, glucose metabolism is another big one. So just to give you an idea of where the developments in the pipeline are moving. So let's talk a minute about tau. So everybody knows about tau. Tau, as opposed to amyloid, which is extracellular outside the cell, tau is intracellular inside the cell. Remember that tau protein is actually a normal protein that sits on a microtubule, which is kind of like the cytoskeleton of the cell. And these microtubule is kind of like transport system, allow the nutrients to go up the cells. So bad things happen when tau gets phosphorylated into PHS or PET helical filaments, and then eventually into tangles. So this is intracellular. And remember that tau oftentimes appear before beta amyloid, but Alzheimer's only arises when beta amyloid coexists with tau, and that's when the tau spread quickly. And we don't know what comes first, but there's evidence to suggest that beta amyloid seems to drive tau and not the reverse. I want to talk to you about one study that we are undertaking here in Hawaii on B080, which is a CELIA study, 247-8201 trial. I gave you the NIH NCT reference there. So what is BII080? So it is an ASO, or antisense oligonucleotide. ASO does bind to the MAPT, which is microtubule. Remember, tau binds little proteins or microtubule. binds to MAPT, which is the so the ASO is the ping, kind of a ping helix here. It binds to the messenger RNA. So remember, messenger RNA is kind of translated into protein. So once it binds to that, it stops the translation. So it stops the translation of tau. And even in the early studies in the mouse model, the ASO appears to actually even reverse some of the tau toxicity. So the Celia study is a phase 2, randomized double-blind, placebo-controlled, to assess the safety and tolerability in MCI patients. Well, how about metabolism? What do you think about that? Besides amyloid, tau, inflammation, one common theme that underlies all those different mechanistic pathway is metabolism. Could possibly metabolism be sort of like the connecting factor? So let's look at some evidence here. So what is really the link between metabolism and Alzheimer's? So, well, we know that diabetics always have higher, almost twice likely to get Alzheimer's. And almost 70% of diabetics develop Alzheimer's if they live long enough. We also know that 37% of Alzheimer's patients are diabetic versus only about less than 10%. So there are several similarities between Alzheimer's and diabetes, which is really the insulin resistance, which leads to cognitive decline, neurodegeneration, and eventually the inflammation and eventually amyloid aggregation deposition. So one study that we are undertaking here is called the EVOKE study, which utilize the product we're investigating is GLP-1R, or glucagon-like peptide 1 receptor agonist. It seems to, the goal is to reduce the neuroinflammatory process and to increase the neuroprotection and cognitive function. This is the EVOKE study. So we have two separate. EVOKE is for just the Alzheimer's, and EVOKE Plus is for Alzheimer's plus small vessel disease. We have two different studies that's undergoing at the same time. So we talk about amyloid, we talk about tau, we talk about metabolism. What about vasculature? You may hear a lot about recent people talk about vascular blood flow. What underlies the theory and what seems to be driving that? So we know that Alzheimer's patients, especially those with a small vessel disease or even those with mixed vascular dementia, have a decreased cerebral blood flow. And we see that a lot in the MRI, in the white matter. You see all this beautiful white matter disease surrounding the ventricles. So we don't know exactly, but we know that when there is a decreased blood flow, there could be a breakdown in the blood-brain barrier, leading to neurovascular unit breakdown. And then that sort of start a cascade when there's oxidative stress and beta amyloid deposits, which eventually leads to the amyloid deposition. So the risk factors are obviously the usual culprit for vascular risk factor: hypertension, atherosclerosis, heart disease. We undertook one recent study, which we completed, called the Psychiatry study, where we look at patients with actually not just Alzheimer's, patients with mixed vascular dementia, which is an exciting opportunity because this is really the first time that we were able to offer our patients with mixed vascular Alzheimer's dementia an option. What did we investigate? The product is CY6463. What is CY6463? It is a nitrous oxide positive allosteric modulator that amplified the endogenous nitrous oxide signaling in the hope, again, to improve the vascular function and to get rid of this here and reduce the neuroinflammation and improve the neural function. So we saw that in the pipeline, there's quite a number of products are in synaptic plasticity and neuroprotection. So what is that? Well, everything that we talk about so far, sort of, if we look at the schematic, this is the diagnosis. If we look at the diagnosis when the patients actually have memory loss. So if you are still using drugs like donepezil, memantine, you're really, this is a symptomatic treatment. So when we test the amyloid and tau products, we are really testing them in perhaps the pre-symptomatic MCI stage. But what we really, so there is, if you've been in the Alzheimer's research field, you realize that we're beginning to test patients earlier and earlier, and now we actually, most of our patients are in the clinical trials here, pre-symptomatic. Obviously we get the spinal tap to document the diagnosis and the amyloid. But what about patients who are sort of moderate dementia? There is already degradation, so is it possible, can we restore neural function at that work? So this would be synaptic plasticity and neuroprotection. What is this? How realistic is this? Play a short clip for you here.
Researchers here in Hawaii are involved in the development of a drug they hope will one day be available to treat Alzheimer's disease.
The drug is now in clinical trial, and patients don't even have to leave their homes to participate.
Millions of people in the U.S. are affected by Alzheimer's. It's currently the 6th leading cause of death in the country.
KITV4's Nicole Tan joins us live tonight with this story. Nicole. Well, Alzheimer's is a disease that occurs when brain cells degenerate and die, causing memory loss and deterioration of other mental functions. Right now, there is no cure, but research teams hope that their results of their investigation can be the start of a cure for the disease. The study is called LIFT-AD. Eligible participants will receive an injection of a new drug once a day for about 6 months. This drug aims to repair the damaged wires that result when brain cells are degenerating.
So the brain cells has little branches. If you think of it as little branches, we're hoping that the brain cells that didn't work for a long time could start growing branches again.
Dr. Liow is leading the study locally and reports there's 5 residents participating so far. For him, the mission is personal.
Okay, so I'm going to take you to the next slide here. Whoops. So I want to talk to you a minute about what this study is about. Is the NIH-funded study called the Thera 1017 Synaptic to enhance synaptic plasticity. So what's the ATH Thera 1017? It is actually a hepatic growth factor receptor thyroxine kinase. It hopes to inhibit inflammatory markers, but also to prevent neuronal death and promote repair. So how does that work? So the goal is to perhaps enhance neuronal network connectivity. Remember that Alzheimer's is a process where the neurons loses the synaptic connection. The neurons degenerate, loses it. Is it possible that we could reestablish some of that synaptic, connection? We know from basic science that synaptic plasticity is a real thing. You could have a long-term potentiation. You could also have long-term depression with continued synaptic stimulation. So can we actually do this in real life? So this is the hope that perhaps by binding to we could sustain some neuronal connections, synaptogenesis by synaptic plasticity, maintain some neuronal and function, and basically to reconnect and reconnect and reestablish some of the network. So what's really the barriers? What do I think is the barriers in some of driving the development of all this? I think one of the big barriers is biomarkers. So we're just gonna camp here for a few minutes because it's an important slide. So we understand that by the time the patient sees you in the clinic, whether you're primary care, you're a neurologist, you're a family practice, what have you, with memory loss, there's a good chance that they would have, either MCI or dementia. There's a good chance, I would say, about 80–90% of my patients by that time have hippocampal volume loss in a temporal lobe. Therefore, their cognitive performance, if you can see the arrow in this big green yellow, is impaired. So the function, and then obviously the function follows shortly after that. So how do we diagnose it earlier? What is the biomarker? Unlike a tumor, for example, prostate, we can get a PSA. We can get an ovarian tumor biomarker. What is the biomarker for Alzheimer's? Well, we have several what we call surrogate markers, but we don't exactly know if they really accurately translate into better neuronal function or memory. But the surrogate markers, the most two prominent use are the amyloid imaging, the PET imaging, as well as the CSF amyloid and CSF tau. You can see that both the green lines at PET amyloid imaging can be detected in a pre-symptomatic stage, as well as the CSF at even earlier stage. So so obviously we can't go around our clinic just putting a spinal tap in everybody that you see, or send them for amyloid PET imaging. We don't actually have an amyloid PET scan in Hawaii. So so that's really, and Hawaii is just one place, but the rest of the world, most of them may not even have the capability to do CSF, or MRI for that matter. So that really is a big deal in really doing trials, because we really lack a good, easily accessible biomarker. So just in the last decade, there's some paradigm shift in Alzheimer's disease. The research definition of Alzheimer's has moved from a clinical, which is mainly a memory loss, to more of a biological paradigm, using biomarkers. So you have Alzheimer's when I see the amyloid in your PET scan, or I see the amyloid, changes, decreased amyloid, increased tau in your CSF. That's how we went moving away from when you actually have a memory loss to actually biomarker diagnosis. So you can either have increased retention amyloid on a PET scan, or in the CSF, you have decreased amyloid because they're sequestered in the brain, or increased tau, phosphorylated tau, and total tau. Or in the later stages, you can see the hippocampal atrophy on MRI, which is what we routinely use here in the memory center. So the question is, so whether we do a volumetric, why are the current biomarkers not ideal? Well, first of all, the MRI, the PET, and the CSF, first of all, they're expensive. Anybody who's ever had to pay out of pocket for an MRI, you know how expensive it is. And PET scan is not even available. Our patients who are doing PET scan currently actually travel to California. We're working with several vendors, several partners, PET site in California. And CSF is invasive. So they are expensive, not widely available, and invasive. What we really need is a biomarker that's non-invasive, widely available, portable, and cost-efficient. So what do? So NIH recognized that even as far back as 2018 in the NIA Alzheimer's Association Research Framework, working towards a biological definition of Alzheimer's disease, moving away again from a clinical diagnosis, from a memory loss or dementia, to actually a biomarker definition. They recognize that, NIH recognized that current biomarkers used are either expensive or invasive. The current generation of biomarkers although it's very good for research, however, we need a widespread, more widely available, less expensive, less invasive biomarker. That's coming from NIH. So this is one of my favorite character here. Everybody know Albert Einstein. One of his famous saying is, in the middle of difficulty, lies opportunity. So I always keep that in mind when I come across a problem or anything in life that's. So the question that I want to throw at you today is, can potentially cognitive signals or neurophysiologic signals be a solution to biomarker challenge? Well, think about Alzheimer's as a loss of synaptic connection, neurodegeneration, dying of the cells, dendritic degeneration. MRI, PET scan, they are all structural markers. They are molecular and structural markers, not functional deficits. Why aren't we thinking about using a functional biomarker? There is evidence to suggest that in Alzheimer's, the problem of synaptic loss and synaptic dysfunction, which is really the key role in pathogenesis. Therefore, perhaps why aren't we thinking about using a marker that measures deficits of brain function, a functional marker, a synaptic activity that measures synaptic activity? So EEG and ERP, or event-related potential, is two potential functional biomarker that could potentially measure electrical activity, which basically measures neuronal and synaptic function, and it can very objectively measures them, caused by progression of disease. So could EEG be tracking the prodromal phase of cognitive decline in the routine clinical settings, which eventually, in combination with other markers, obviously you still need the MRI, and obviously, but could this be a widely available, less invasive, and cost-efficient way? So is this something that's already done? Absolutely. So in several of our studies, we are measuring ERP. So let me just take a minute to explain what is ERP. ERP is event-related potential. So we are measuring in normal subjects. So we give them a visual image on the computer, and then we measure the event-related cortical generated potential at the occipital and parietal cortex. So in the normal individuals, in the blue curve here, that should be about P300, or P for positive 300. But we know that in Alzheimer's patient, it is delayed to almost as far as 400. Another good tool for functional measurement or synaptic activity is quantitative EEG, especially in the fast activity in the beta and gamma. Gamma activities, beta are more than 12. Gamma activities are more than 25 hertz. So those are two potential biomarker I want to talk to you a little bit more about. So here's another schematic from one of our clinical trial that we are already using. So remember that when we talk about Alzheimer's, going from a healthy brain to an Alzheimer's brain, we're really talking about loss, synaptic loss, loss of connectivity, loss of neurons. So we're talking about functional deficit here and loss of connection. So as the connection are being lost, we see a decrease in the gamma. Gamma is more than 25 hertz power, and also prolongation of the ERP, event-related potential, from 300 milliseconds to 400 plus. It's a progressive, obviously, continuum. So this is actually the data from our most recent study, the NIH-funded study on Thera, which now has the name Vascular and Dementia. These are patients on Thera and acetylcholinesterase inhibitor, looking at the change from the baseline in the ERP P300. So patients that are on the drugs seems to have improvement, less change in the baseline, and patients on the placebo seems to have declined. So these are real life application that some of our clinical trials are already putting into place. What are there other evidence? Well, there are other evidence. I want to point to several studies as well, coming from behavioral brain research, looking at patients with the ApoE4 impairs cortical activity in healthy aging and Alzheimer's disease. So we can actually look at patients who, patients without memory loss, but at high risk because they have both sets of E4 allele. Remember that those, if you have E4 and E4, you have tremendous, at least 12 times increased risk of Alzheimer's as opposed to having two sets of E2 and E2. So this studies look at patients without memory loss, but have E4 as well as amyloid positive CSF. So here again is looking at the P300 patients who are carriers, which is the red, seems to have delayed P300. Again, same thing here at the bottom line. Patients who are carriers, Alzheimer's disease, E4 seems to have delayed evoked potentials in the red curve. And patients who are non-carriers with less risk seems to have the blue curve, seems to have a less the latency of normal, closer to 300. So the other thing that we talk about is connectivity. So how do you measure connectivity in the brain? So you could measure connectivity in the brain with several ways. In the EEG, you could look at complexity of the EEG, or synchronization of EEG is synchronized when all the neurons seem to function together. So I want to talk to you about this studies done in Sweden, again published in the brain science, where they look at EEG synchronization in amyloid positive. So this patient's already either had a PET scan or CSF positive. In patients with MCI and Alzheimer's, and the relationship to E4 again. So in patients with E4, which is the red, you see that first there is a decreased beta in the global field synchronization. So there's decreased beta activity. Remember, I told you that the beta would get less and less as the connectivity is lost, as the Alzheimer's progress. But also the synchronization or the connectivity is measured, and there's it seems to have also decreased over time as well. So another study that came out this year in Frontiers in Neuroscience, and looked also at genetic association of E4 with EEG alpha rhythm slowing. Again, patients who are E4 positive, remember they're slowing. This is their frequency. The frequency seems to have a slower EEG, patients with E4. And this is on the left hand of the graph. It shows the purple are the slow frequency. That's increasing slow frequency anterior part of the head. This is the nose, and even in the posterior part, you can see that patients with E4, which are at high risk for Alzheimer's, tends to have slower frequency. So that's a fairly good correlation. What's really exciting to me is question to authors is, it is complicated, synchronization. We're talking about complexity, looking at functional synaptic plasticity, lot of. Could we possibly have a machine learning approach, where we can feed all this information to screen for preclinical Alzheimer's, so that this is being done in Europe. So there is an article from Neurobiology of Aging that just came out last year, where they looked at 304 cognitive normal individuals. What they looked at is they look at their MRI findings, they look at their PET findings, CSF finding, they look at their amyloid status, they look at the decline, and it shows that EEG was the most strongly predictive of neurodegeneration, even when reducing the number of channels from 224 down to only 4-channel EEG. That was very, very exciting to me. That the combination of demographic, physiologic, psychological, ApoE4 hippocampus most strongly predicted amyloid. And we can actually use AI or machine learning to help us to sort some of this algorithm out. So that was really exciting for me. So I want to tell you a little bit about what we're doing here in our Hawaii AI Brain Mapping Lab. I have that's our wonderful team here with Dr. Vimala to my over here, and we have a medical student working on this project every year. The current med student is Carissa, and Nathan is the second year, Carissa third year, and Enze is the fourth year med student working on this project. What are we doing? We are looking at cortical neurophysiologic signals. We're looking at patients who have we're looking at EEG findings based on the amyloid status, CSF status, amyloid status, and also on their genetic E4 allele status. And this is one of our patients getting their evoked related potential. That's another medical student, Connor, over here. And this is where we record the evoked related potential. They're looking at a screen. So what's interesting about this project is when I asked a med student, when does this UHIRB approval expire? And I said, Carissa, is that a mistake? The expiration date shows August 27, 2069. I'm going to be over 100 years old, I told her. She said, no, so I was really surprised we granted UHIRB approval for that long. But I'm not going to be around for that long, for sure. Maybe Carissa will and Nathan will. So what are we studying? We're looking at patients ages 64 to 78. That's seen here at the Memory Center, MMSE more than 28. So we wanted them to be almost asymptomatic at the time. So we know their amyloid status. We have the CSF amyloid status, and we know their ApoE genotype status, and we looked at the EEG. So almost 50% of patients noted some sort of abnormal temporal slowing, so loss of their gamma, beta activity, and moving towards, there's a high ratio of delta and theta over a high ratio of low frequency over high frequency. And for some reason, 10 out of 19 had focal left temporal slowing, 9 out of 19 had bilateral temporal slowing. And patients with E4, the E4 carrier seems to have a higher incidence of slowing as opposed to who are negative non-carrier E4 slowing. So what did we conclude? Our data concludes that individuals with the E4 allele, which is at increased risk for Alzheimer's, had higher percentage, some abnormal slowing, especially temporal slowing. For some reason, more on the left than the right, compared to those who did not have, were not at risk without non-carrier. Obviously, this is a small sample size for each genotype groups. So but the study is continuing on, and very glad to continue to work with our medical students. And credit to Dr. Vimala Vijala and Dr. Virag, Dr. Kurzana, our neurologist, for helping with this project. We presented some of this finding at last year's AAIC, Alzheimer's Association National Meeting that was accepted. Enze, who is a fourth-year medical student, presented findings at that meeting. Very happy, very proud of our students. This year, their findings are being accepted to be presented at the American Epilepsy Society, or the Predominant Society for EEG Findings. Again, Nathan as the first author, Carissa second, Enze fourth-year medical students, third-year and second-year medical student. The project actually started with Celine, who is a resident now. Obviously, this project has been ongoing for several years. And again, credit to our faculty, wonderful neurology faculty, Dr. Kurzana, Dr. Virag, Dr. Vimala, who has done a lot of work in this project. Again, I give credit. I want to acknowledge our wonderful team at the Memory Disorder Center, Alzheimer's Research Unit, our neurology faculty, and also our mid-level provider, Chris Larinaga, Nicole Little, Todd Uchima, who have really assisted us tremendous deal on many of our clinical trials. And also our neuroradiologist, Dr. Ricardo Burgess, who does our CSF. I also look at our MRI volumetric analysis. And picture below is just some of our students that are working with us in the Brain Research Innovation Translation Lab. several of them are also working on Alzheimer's projects with us. Yeah. So many many researchers have asked me what do I feel about this field. This is so complicated, and we're really not making great progress, are we? So I have. This is what I live by in my life. I see problems really as opportunities. I'm a firm believer that problems don't have to be a problem unless you allow them to be. Perhaps this is the neurologist in me. As you know, neurology is all about problem solving. I believe that problem solving is a choice. It's not a function of circumstances. No matter how difficult the circumstances may seem, there's always a solution that not only solves the problem, but has the potential to improve lives and develop leadership. It will definitely develop a lot of character on the way as you overcome, as you persist and make sacrifice to solve the problem. I believe that every opportunity and problem is a gift from God. So you might as well make the best of it. You're going to always have problem in life. Might as well go enjoy the ride, right? So what does 2022 in the future looks like? So here it is. This is the 143 drugs that are in the pipeline in the world, in the US and the rest of the world. So this looks a lot like a Chinese zodiac graph, or maybe a dot board. You just want to throw a dot at it and see where you hit. But let me just take a minute to explain that. So on the top, you have the disease-modifying biology, and then on the purple, you have the disease-modifying small molecules, which is very popular pathway to get there. Obviously, the products on the outside of phase 1, a lot of them, and then the middle circle is phase 2, less, and then obviously when you get less products being phased out, and then less and less in phase 3. So the red products are the amyloid. You can see quite a few phase 3 are amyloid products, including aducanumab here, donanemab, all the mAbs here, but as you go out further and further, you see less and less red. So seems that, and that's a good thing. We see some inflammatory products being developed, synaptic plasticity product being developed, and the exciting thing is also a lot of small molecules being developed, especially in the phase 2 arena. So this are really exciting. Out of the 143 drugs in the pipeline, the exciting thing is 83% are disease modifying, involving 50,575 participants. And many of them are also here in Hawaii. I want to thank all the doctors that have supported Alzheimer's research here in Hawaii to make this possible. I want to finish this talk by telling you a story about an Alzheimer's patient. The lady on the left side, her name is Susan. She developed Alzheimer's. Her initial symptoms were obviously a short-term memory loss, and eventually it progressed to a loss of function, couldn't remember names, and so families tried to take her to the big academic centers back then to try to find options. Fortunately, this was almost 20 years ago when she was diagnosed, and there was very little option her family could have done for her. And this is her husband. His name is William. And if you see that William I kind of look like William. There's no coincidence. William is my father, and Susan is my mother. So this is my mom and dad. And my mother passed away from Alzheimer's 15 years ago, and which is why I'm inspired every day to do what I do. I'm very honored. At the same time, every day I think about how I was without option when she was diagnosed 20 years ago. There was very little I could have done for her. So I just wanted to dedicate the session to her and many of our Alzheimer's patients, the families and caretaker we get to humbly serve and learn from every day, and who continue to inspire us to do what we do today. Want to finish by letting you know about my goal is to try to bring as many of the Alzheimer's study here to the island as possible. Things that my mother would have loved to be part of, but just didn't have the opportunity. But for patients with preclinical to MCI, MMSE more than 22, obviously, if you're early enough, you do need an LP to confirm your diagnosis. We have oral options, Evoke, which works on metabolism, glucose metabolism. Then we have IV, monthly infusion, which is the aducanumab, works on the amyloid. And then we also have intrathecal cilia, intrathecal every 12 weeks cilia, which works on tau. So we have different options to take it and different mechanistic pathway, PO, IV, IT, intrathecal, different mechanistic pathway. Patients with mild to moderate dementia, MMSE 14 to 24, we have sub-Q injection, which is a synaptic plasticity neuroprotection trial, the LIFT-AD. Please thank you to all the doctors who contribute to this trial and have your patients contribute to this trial. Only by doing clinical trials can we really advance the science for Alzheimer's. We have a research hotline, call at any time. Or feel free to email me if there's anything that I can do for you. So once again, I thank you. My special thanks to Department of Psychiatry, Tehani, and for allowing me to speak to you. And thank you again, once again. I'm happy to take any questions.
Thank you, Dr. Liow, for speaking with us today. Does anyone have any questions or comments for him?
Hi, Dr. Liow. I just wanted to say thank you so much for the wonderful presentation and, sharing your story and everything. I just had a quick question about the APOE4 allele study and the EEG findings. Were you able to have enough patients to see if there was any dose response with 2 alleles versus 1 allele? Because I think you're at greater risk for Alzheimer's if you have 2 alleles, if I'm correct.
That's for sure, yeah. So your risk is, if you have one set is E4, what we call heterozygote, it's about 4 times. If you have monozygote or two sets, it's about 12 times. So we don't have enough data. Thank you for the questions, the good questions. Our sample size is small enough, so to be able to study that, we need not only that we need the E4, we need actually the amyloid status as well. So we actually sample their CSF to look at whether they're amyloid positive. So we need to know that they're amyloid positive for the studies to mean anything, not just the fact that they have ApoE4. Yeah. I believe, so there are other studies that have looked at this. The homozygotes tends to have a slower frequency than the heterozygote, or what we call HT, compared to HM. I know that there are other studies that have looked at this. They have a little bit bigger sample size. But yeah, no, I thank you for all the physicians in town who refer their patients. Just know that I'll be looking at the EEG. This is kind of how I track how your patients are doing, using the EEG to look at their synaptic function, their connectivity. So hopefully that answers your questions.
Yeah.
Any other questions or comments? I see Jacob Lee commented in the chat.
I can't see the chat. Would you?
Oh, it
is
says
that something that you're able? Okay, thank you.
It says thank you for this topic. Biomarkers are desperately needed to bring the toolkit of psychiatry, neurology to parity with the tools other specialties currently enjoy. Of course, the same is true for new medications.
Thank you.
Okay. Looks like we'll wrap it up, I guess. Thank you again for taking your time to speak with us today.
My pleasure. Thank you. Aloha.
Have a good weekend, everybody. We'll see you next week.